Yeah, good evening. Today I'll be talking about the coexisting diseases of both cataract and diabetic macular edema in a particular patient. Two diseases that we keep seeing pretty frequently, and how we manage day in and out in our routine practices. Is the management of diabetic macular edema involves not only how to treat along with the coexisting cataract, but also counsel the patient the likelihood that they will develop a diabetic macular edema in the post-operative course. There is a very good study, UK based on the electronic medical records, where they found that the roughly the 6 months is the time when the incidence of diabetic macular edema increases following the cataract surgery. So this is important piece of information that we should pass on to a patient during counseling. And irrespective of the stage of the diabetic retinopathy, no or mild, moderate, severe, the incidence of diabetic macular edema after cataract surgery doubles at roughly about 6 months post cataract surgery. And similar thing explained. And the management of these two diseases includes a good preoperative assessment that along with a good metabolic control and treatment of macular edema and the cataract surgery and follow-up. So the important thing is to grade the cataract along the extent of the cataracts, nuclear, posterior, subcapsular, depending on suitability for laser, and also grading the retinopathy and the macular edema, not just the macular edema, overall whether it is a mild, moderate, severe or a proliferative diabetic retina, and relative contribution of these two factors in the visual loss of this particular patient. We should make sure that along with the macular edema, we stage the retinopathy, whether it is PDR is involved or no. We can see that the wide field fundus photography gives a better detail in staging the retinopathy. This is a lasered patient, and in the examination we can see that there are new vessels elsewhere. So we pick up new vessels, and this patient ideally need to be done a PRP before cataract surgery. This is again following a focal laser, presumably innocent, but we see that there are new vessels in other quadrants than we see. Yeah. The grading of retinopathy is important when we, in these patients, that involves detailed indirect ophthalmoscopy and also OCT angio if feasible to avoid invasive tests like FFA, and also look for undilated slit lamp evaluation in high risk PDRs to look for any early NVI or NVA. We see that most of the time they deteriorate into neovascular glaucomas soon after cataract surgery because of undetected new vessels. And it's better not to get fixated about central foveal thickness or central macular thickness, because some thick retinas see well, some things don't. There are various biomarkers that one should actively look for in these patients, especially like derangement of normal retinal inner layers that indicates macular ischemia. As well as look for the outer horizontal outer lines in the outer retina that could indicate a photoreceptor damage. So we can prognostic a patient accordingly, and also look for intraretinal interface disorders that probably will help in doing a combined surgery in these patients. OCT angio is very non-invasive and document macular ischemia that could help in prognosticating a patient of diabetic macular edema regarding the poor prognosis as well as probably poor response to intravitreal injections as well. And a good diabetic metabolic control before cataract surgery in high risk individuals is good, because that decreases the severity of the retinopathy, as we can see in this patient. And whereas focal laser, now coming to focal laser still has a role, especially in non-center involving diabetic macular edema. These are the patients once after cataract surgery they could progress to a diabetic macular edema requiring intravitreal injection. So focal laser and non-center involving macular edema is good. And if there is a significant cataract, especially if the yellow laser with its properties of longer wavelength and less scattering, we can do a good PRP or focal laser in spite of this thick cataracts. Now, mostly the discussion will be on these kind of diffuse diabetic macular edemas, the treatment. Cataract in this treatment naive diabetic edema, the aim is to bring the central foveal thickness to less than 250 microns. I would prefer to give a dexamethasone implant and followed by cataract surgery after 3 to 4 weeks once the edema comes down to normal, and use anti-VEGF in case of established glaucoma or in cases on 2 or more drugs. This is a patient managed in a similar way, intravitreal dexamethasone implant followed by cataract surgery after 1 month. And then And DME, if the patient is on anti-VEGF injections and patient has a diabetic macular edema, I'm a firm proponent that it's better not mixed at the time of cataract surgery. And mostly I advocate and follow this procedure. Best to plan cataract surgery 7 to 10 days after intravitreal injection. And idea is to bring the retinal thickness to less than 250 microns before cataract surgery. And and it's the drug to be used for all steroid responders and PDR patients and all. And cataract patients, if there is a high-risk diabetic PDR with DME, if there is elevated FVP, it's best to give a dexamethasone implant followed by PRP at the 1 month after cataract surgery. Yeah, this is a patient of diffuse diabetic macular edema with cataract managed with anti-VEGF injections, and subsequently cataract surgery was offered to this patient. Now, combining cataract surgery with intravitreal injections, this is probably best avoided because there is no advantage, and it's always good to, and in case of any post-operative inflammations, infections, it's difficult to diagnose and treat, and nobody gains anything by combining these two procedures together ever. Yeah. And cataract surgery patient, one should keep in mind that it's better to avoid pre and post-operative antibiotics because you're likely developing resistance to this bacteria, and if at all you're very keen, better not use fluinolones, or you could use some other antibiotic which has a lower profile. And during cataract surgery, anticipate slightly higher risk of inflammation or PC rupture in this kind of patients. And this I would like to thank my colleague Dr. Dipender for this slide. And the risk of PCR following injections is high following dexamethasone implant, and higher chance of retained lens material and increased end-off following dex implant. The patient, cataract surgery being performed after intravitreal Ozurdex injection, PC rent being managed without Sen? This is basically after intravitreal injection when cataract is being done, develop PCR.
This is for cataract surgery being done after multiple anti-VEGF injections.
Yeah.
Odds ratio was high.
Thank you.
No, that one video.
I'm just saying that these particular group of patients are more likely to have PC ruptures during the cataract surgery.
That was a nice article actually. It's a high odds ratio.
Rami, why are you against cataract surgery? You said patients on injection avoid this surgery.
So come again, sir. Simultaneous.
Because patient will always thank the cataract surgeon, not you. Then I'm telling you, because this in practice this dilemma occurs. You keep treating retina, so you refer for cataract. He is thankful to him only, not to you at all. So always.
Because ideally, I feel
because you people, I don't do cataracts, but you people, young people, can do cataract and both. So I will, because patient visual improvement generally will occur, by 2-3 lines post cataract surgery. So you'll also be thankful.
No, the point Dr. Lalit is raising is if the cataract is significant. That's the
obviously.
point.
I'm not talking of 1, 2, 3.
So we know a lot of patients where the cataract surgery does not result in visual improvement also. So when not to touch that.
No clinical advantage of giving them together unless you are giving a prophylactic injection to take care of edema which is not there.
No, can you show the third, fourth slide, because you said cataract surgery.
Yeah, that's what I advocate, and mostly not because I think it's unless there is any specific benefit, because patients are anyway used to taking monthly injections. For them, compliance of it's not like combining phaco and vitrectomy where
we keep giving injections. He goes to some other surgeon who is a general ophthalmologist. He will do cataract surgery. Doctor साहब उन्होंने ठीक कर दिया.
So that.
When you are giving injection is to control macular edema
Yeah.
before cataract surgery. If you are giving injection at the time of surgery.
I'm not saying give at the time. I'm saying what I'm saying is keep the patient with you and do cataract surgery.
Yeah. Of course. That's
No, but would you ever give at the time of
No, that's what I meant was at the time of cataract surgery, never give a intravitreal injection.
So there was a study from PGI where they gave Ozurdex in all the cataract surgeries.
No, they are probably. I generally don't subscribe and I don't advocate that.
I had a question. Do you agree to the premise that the cataract surgery would worsen the progression of the diabetic retinopathy severity?
Yes, I think there's enough literature shown that it almost doubles the risk of diabetic macular edema. Yeah,
But my question actually is that do all the cases actually progress, or there are certain cases which have a higher HbA1c levels which are operated with a normal FBS and a PPBS?
I think likely
There
the
is an
ones that
article-
progress are ones which have probably worse control.
Anything more than moderate, they do progress. Mild. And,
This is the study that shows that in all grades of retinopathy, incidence doubles following
So
cataract.
the next question actually is, does the retinopathy progression and the maculopathy progression, are they together similar or are they different? The question is
Yeah.
whether the progression that we are talking about.
Yeah, I think what we have enough is about maculopathy progression, not diabetic retinopathy. Does not progress in the 6 months' time. It's the edema that progresses worse after cataract surgery.
Answer that. I think I actually did a very interesting study. I presented it, I think.
I think there's a DRCA.net protocol which has said that if you have macular edema, so if you do not have a macular edema but you have a non-proliferative diabetic retinopathy, go ahead and not do cataract surgery, it will not progress.
Correct.
But if you have a macular edema with NPDR,
This is where I was coming to.
then you can do cataract surgery, then maculopathy, that's what he's saying. If you have maculopathy, it will progress.
No, the question actually is the progression matching the progression of the maculopathy, and suppose there is
No,
also...
probably it doesn't match. Diabetic retinopathy does not progress so fast. Diabetic macular edema is the one that worsens
See,
after cataract.
early phase, if there was no pre-existing, I would look at Irwin gas more in the early phase.
Ashish, can you please?
Thank you.
Thanks.